Welcome, everyone, and thanks for listening to Sports Doc Talk. Be sure to check us out at sportsdoctalk.com. All sports, all orthopedics, all the time. I'm Will Sanchez, and we're really excited about today's guest, Dr. Wayne Weil, board-certified orthopedic surgeon with subspecialty in training hand and elbow surgery. He's recognized as Seattle's top doctors, and one of our own Seattle's top doctors, Dr. Grant Garcia, is with us. Dr. Garcia, welcome. How excited are you about our guest today?
I'm very excited. I was excited to invite him. You know, Dr. Weil is a fantastic hand surgeon, does lots of sports hand surgeries. And as one of my partners, I get to see him do them every day and be impressed by the technology that he's using. He helps me with Mercer Island teams that we take care of and does all the hand stuff for us. He's a fantastic partner and friend. In addition, you may have seen our segments recently on the dual surgeon approach. We just posted another one, episode 5 of 10. And so for these really complex elbow cases I tell you about, he's really my go-to and has been really helpful for that. So I'm really excited to have him on the show. Hopefully we can pick his brain and hear more about sort of the cutting edge tools. And really it's nice to have one of the top hand and elbow surgeons in the Washington State with me. So it's really excellent. So thank you, Dr. Weil, for being on here.
Pleasure to be here with you guys today. We're really excited.
So I think, we can go so many different topics today, but the one we always hear about, and I know we see it pretty much always in the news or ESPN, is the sort of gamekeeper skier's thumb. Will you tell us a little bit about this, sort of the treatments you're doing for it? Or maybe some athletes you can think of, off the top of your head that have been treated with this?
Yeah, I think that's a great place to start. Gamekeeper's thumb or skier's thumb, it's a super common injury at the thumb metacarpal phalangeal joint, which is kind of that big knuckle on your thumb. And basically, you can think of that ligament as the ACL. You've all heard about the ACL in the knee. This is basically the ACL of the thumb, and so it's a common injury in ball sports or in any sport where the hand is outstretched and people are falling. So mountain biking, skiing, skateboarding. And again, ball sports, especially basketball, and then baseball as well. And basically what happens is, let's say in baseball, this is probably now 5 or 6 years ago, Bryce Harper sliding into third base, and his thumb got caught on the base and wrenched his thumb back and tore the ulnar collateral ligament. And basically what happens with that is you lose the stability in the thumb for power, pitch, and grip. And obviously somebody who's holding a baseball bat needs that power, pinch, and grip. Or somebody who's riding a mountain bike or holding a ski pole, or even our weekend warriors who are just trying to hold a golf club, or somebody in the kitchen trying to open up the pickle jar. If you've torn your ulnar collateral ligament, it really affects your power, pinch, and your grip. And so in athletes, this typically was a fairly debilitating injury in that it would oftentimes be a season-ending injury. Because after a repair of the ulnar collateral ligament, typically we'd need to put you in a cast for 6 to 8 weeks. And then there'd be a long rehab time afterwards. And so the full recovery was roughly 6 months, which was basically a season-ending injury. And over the last, really about the last 5-6 years, hand surgeons, we've borrowed a bit from the foot and ankle docs and from the knee docs, and I've started using a technique called an internal brace. And with that internal brace, we can augment our ligament repairs. And instead of a 6-month recovery, we can get folks, especially pro athletes, back to sport in about 6 weeks.
Wow.
And it's been really gratifying to treat our athletes and even our weekend warriors with this technique, because we can get people back to doing the things they love doing in such a faster fashion.
That's awesome. Well, thank you for that update. I know that Will is very excited. This is probably, the internal brace is probably his favorite topic ever. So we've gone through the round of internal braces all over the body, and now, we have another reason for Will to get excited. He can do internal brace of the thumb and the UCL.
I love it. I think it's absolutely incredible, the internal brace, and hearing about the recovery from athletes and just everyone in general. Just a quick follow-up. You mentioned golf. We think about the golf grip. How many injuries do you see from golfers? I'm not a great golfer, so sometimes I take a swing and I'm slamming right into the grass, and all of a sudden I'm feeling that reverberation kind of shooting through my hand and my wrist. So what kind of injuries are you seeing when it comes to golfers? Because believe it or not, 1 in 7 Americans play golf in 2022. And a follow-up to that is there a grip that may prevent less injuries, open or closed grip?
Yeah, that's a great question. In terms of the actual grip itself, not really aware of any one being better than the other. I think really it's all about, the mechanics of the ball striking. And really, I think a lot of the injuries are coming from essentially what you described earlier is sort of those swings that don't end up being as sweet as we'd like them to be. And, you take a shot really fat and you hit the ground really hard. And that can cause a number of different injuries. Number one, wrist injuries. There's an area of the wrist kind of on the pinky side of the wrist called the TFCC. It's one of the ligaments of the wrist that helps stabilize what we call the ulnar side of the wrist, or the pinky side. And that acts kind of like a meniscus in a knee. It's a bit of a shock absorber, and that can be torn with a pretty violent impact into the ground. Other things that can happen is you can have it's a rare fracture, but it's a somewhat common fracture in golfers and actually baseball players as well. It's called a hamate fracture, or a hook of the hamate injury. And then other injuries can be a lot more of a chronic nature. People can develop a golf elbow, which is similar to tennis elbow, but golfer's elbow happens on the inside of your elbow as opposed to the outside of your elbow.
I think, Will, you got a perfect segue for your Mike Trout question.
Well, I didn't want to jump in here, but I mean, you mentioned the hamate bone, and for all you baseball fans out there, the loss of superstar Mike Trout, he suffered that fractured, and I mean, correct me if I'm wrong. First off, if you could describe the hamate bone injury, they're saying that he's going to be out 4 to 8 weeks. He has a cast from his hand up to his elbow. So that seems like a pretty serious injury. But is that injury common or uncommon? And then following up, what does that mean, the fact that his hand all the way up to his elbow is donning a cast?
Yeah, so it's one of those injuries that I like to call uncommon but common for me as a hand surgeon. And in the general population, fairly rare. In my practice, seeing a lot of baseball players, a lot of golfers, I see it fairly often. It's often misdiagnosed and missed in general, but essentially the hamate bone, if you're looking at your hand and you push on the pinky side of the heel of your hand, you can feel a little tiny protuberance in there, and that is what we call the hook of the hamate. And the hook of the hamate is important in that it acts as almost like a pulley or a lever, so that your flexor tendons to the ring and the small fingers, which are what give you your power grip strength, they key right off of the hook of the hamate. And so if you have a fracture off of the hook of the hamate, those jagged edges of bone can cause the tendons to tear as the tendons ride back and forth over that fractured area. And the other big problem with the hook of the hamate is it has a pretty poor blood supply, so it's a tricky bone to get to heal. And so the reason Mike Trout is now in a giant cast for this tiny little bone, which is smaller than the size of a peanut, that the goal is to just completely immobilize everything in the hand. And the way to do that is with this giant cast that goes above his elbow, because you need the cast to go above the elbow to prevent rotation of the wrist. So moving your palm from the palm up to the palm down position, as well as just the flexion and extension of the wrist. And the doctors treating him are really trying to keep him out of the operating room, because the next step, if the bone doesn't heal, is an operation.
So kind of talking about more of the sort of hand bones, et cetera, but also kind of moving on, different topic. I've seen some sort of crazy stuff you're doing now with, as we get older, or people do a lot of pinch grip, you get some arthritis in sort of the base of your thumb. We call it CMC. And you're doing some things now. We used to see remove it, put extensor tendons in there, and I think you probably still do that. But there's some other ways you basically are doing the similar stuff that I'm doing in the knee, sort of cartilage restoration, and other options for people that are younger, because those procedures aren't really as good if the other older procedures aren't really as good for young patients. So what are you doing that's sort of more innovative in that area? And are you doing arthroscopy? Are you have any other implants you're using? Tell us about that.
Yeah, it's a great question. It's a big interest of mine in terms of solving this problem of base of the thumb joint arthritis. And traditionally, the operation of choice was to remove the arthritic bone called the trapezium, and then put in a spacer, typically a portion of one of the forearm flexor tendons or one of the thumb extensor tendons. And this operation works really well if you're 70 years old. But in somebody who's maybe in their mid 40s or 50s, who has kind of early onset of this problem, it's been a big problem for us to solve in terms of, well, what do we do for these folks? And like I mentioned, with the internal brace, that we sort of stole the idea from the foot and ankle docs. For base of the thumb arthritis, we're sort of borrowing from our knee colleagues in terms of techniques like arthroscopy. So now we can do, now that the cameras and the instruments from the knees have been miniaturized, we can now work in the smaller joints in the wrist and the hand. And so arthroscopic surgery at the base of the thumb is something that I enjoy doing. And oftentimes in young folks, this is my first step in terms of treating this issue. We can debride different cartilage lesions, and we can debride any inflammatory tissue that's in the joint, and hopefully buy folks a significant amount of time before having to do any major operations. And then kind of next up the line from our surgery is surgery to try and basically put a spacer in between the two bones, the trapezium and the thumb metacarpal. And by doing that, oftentimes we can preserve the normal anatomy. there's a reason why that trapezium and that thumb metacarpal are there to begin with, and so trying to keep them there for as long as possible just makes intuitive sense to me. And so we have different implants that we're now using that work as spacers. And then once we go beyond that, there's also a lot of interest in a technique that we're using called the tightrope technique, where instead of having to sacrifice some of the tendons of the forearm to recreate some of the ligaments that are required for thumb stability, we'll use a tightrope implant. And again, that's something that's been miniaturized and kind of stolen from our foot and ankle colleagues. So there's a lot of new surgical procedures that we're performing now that I think really will be incredibly beneficial to my younger patients, where we don't see that the traditional surgery that we do for a 70-year-old is going to hold up in an active 40 or 50-year-old.
I think that's a great comment. I think it's important for listeners to hear this, because I think, as Dr. Weil knows, I do a lot of the knee stuff, and I get a lot of patients, even in their 50s, that come in and they were only told the only options are replacement, right? Or the only option is this sort of extensor tendon salami technique that's really for 70-year-olds.
Right.
And so it's important for the patients to know that there's other options out there, and these are innovative. They're still cutting edge. We don't have 20 years of data on them, but they work really well. Things I did a couple surgeries today that they're only about a couple of years old, but nonetheless, they work very well. And so it's important to understand that those techniques are offered, and the second opinion is very important. So if you've seen somebody you're not exactly sure, get another opinion. Always good to get another opinion, especially when you're younger and you don't want to have an end stage procedure. Once you get that trapezium removed, there's no going back, right?
Yeah.
So it's important to have those options.
And that's one of the things that I think is really important in our younger patients is trying to find solutions that fit younger active patients. An operation that's really good for a 70 or 80-year-old is not necessarily good for a 30-year-old. And really what we're trying to do here is tailor our treatment to the individual patient. And again, a 30-year-old is not an 80-year-old. And so we got to have techniques that we can use for our young active patients.
That's awesome. Well, I know we for a hand surgeon, you see a lot of hand fractures. So are there any sort of, and wrist fractures. So are there any sort of innovations that have come up for you, and there are ways to make your patients do better? The old school way is you break something in the wrist or you break something in the hand, you're immobilized for a long time, you're stiff, and you complain for 6 months that you're getting over it. And I know there's newer things out there that you're doing. Your patients are not, I don't see hundreds of casts in the office when we're in clinic together. So you're doing something different. So tell us what you're doing, and tell the audience a little bit more about that.
Yeah, that's also, I think we're in a really exciting age in orthopedics in general. Over the last 20 years, there's just been a huge wholesale change in how we think about things in general in orthopedics. And I'm lucky enough to have gained in the early 2000s. I finished med school in 99. And so I've been kind of witness to this whole transformation in orthopedics. When I was a resident, a hip replacement patient stayed in the hospital for 4 or 5 days, and now they go home after an hour and a half in the surgery center. And similar in the world of hand surgery, with wrist fractures, for many years people were treated in awful casts, and then their wrists came out of the cast and they were crooked and looked horrible and worked even worse than they looked. And then there was an interest in external fixators, which basically looked like an erector set that was pinned to your arm, and nobody liked those either. And they worked maybe marginally better than a cast. And then there was an interest in instead of doing these erector sets, to maybe putting in some plates and screws. And that was really began the evolution of how we treat wrist fractures and especially distal radius fractures in general, to the point where now we've got what's called the volar plate, which is the volar side of the hand is the palm side of the hand. So volar plate and fixed angle devices, which basically means the screws lock in to the plate, and it creates really stable fixation of fractures, and think of it kind of like an internal cast, to the point where at this point, after an internal fixation of a distal radius fracture, I don't use a cast anymore. There's no cast. It's just a soft bandage after surgery. Folks start their physical therapy 3 to 5 days after surgery. So they start their physical therapy before I even see them in the office, which I see them in the office at 2 weeks after surgery to take out stitches. But they've already had a week of physical therapy before they've even seen me post-operatively, which just basically, like any other surgery, I'm sure like all your operations, Dr. Garcia, as soon as patients hit physical therapy and they can hit the ground running, it just speeds up their recovery so much faster. So they're, back to work, they're back to sports, back to regular life, months and months ahead of where they would if they weren't engaged in that PT right away. So the volar plate has been a huge advancement in the world of hand surgery, and it's really gratifying to be a part of that kind of wholesale change in how we treat these fractures. And these fractures represent 1/6 of all fractures seen in an emergency room. So one of the most common fractures that we see, and I see 10 or 15 a week. So it's super common, and it's great that we have a great solution for it.
Well, that's amazing to hear. Well, I think it's excellent to hear that we have such a good person to take care of those in the area. So thank you again for that information. I think there's something I'd like you to kind of share, because I know that we've all talked about this special rehab devices we use and things like that. I know you just recently you did a couple patients with your fractures and this new machine, the Rebless, which you've also done with your elbow patients. Again, still working on, outlets for it and insurance things and everything else. But will you tell the viewers, they've probably seen your insane surgery you did on the elbow of that kid, that every part of their body was stuck, and you've been able to find ways to offer. Probably one of the only ones. You're one of the only ones in Washington I know that's hand surgeon that has this opportunity. So it's pretty amazing to have this device. Tell us a little bit about your sort of experience with it and how it's helping your patients.
Again, I'm a huge believer in motion. And if we can fix fractures and fix ligaments in a way that we can get them moving as quickly as possible, then we have the opportunity, I think, to really get out of the gates running quickly. And with this new Rebless device, I think it's awesome. It's just, again, it's all about moving people quicker. And the great thing about it is that because we can monitor our patients remotely now, it just makes us be able to really dial in people's therapy protocols basically on a personalized level. It used to be that we would, make physical therapy prescriptions, and it would be, one size fits all, and sort of like our thumb surgeries that we're trying to really individualize to the patient. This device allows us to individualize patients' rehab protocols right from the get-go, and it's so scalable in that there's so many variations that we can tweak with this device, whether it's just simple passive range of motion versus active and active assist range of motion, which means, just moving the joint versus actually having the patients fire the muscles and start their strengthening protocols. And it's so adaptive. I mean, you can use it in the knee, you can use it in the elbow, we've used it in the wrist now. So it's really, I think, again, very exciting to be an orthopedic surgeon in this day and age, because we have so many better tools that we can provide to our patients, and we're getting such better outcomes than we did 20 years ago.
Well, and I think the important thing that the listeners need to hear is that, we talk about all orthopedics, all sports all the time, but it's more than just the surgeries, right? And I think Will's seen this before, where there's lots of things that we are non-surgical we treat, but also in the surgeries, it's not just the surgery. That's the part that everyone finds is sort of the sexy, glamorous, technology-driven, but really it's the post-operative is very important. And as you heard from Dr. Weil, he does an amazing surgery, but if that patient doesn't move, they don't look good.
Yeah.
And so he's talking about ways to accelerate everything. And so when you do that, that's when you have patients rocking it in the office at 6 weeks. And so having the device plus the good surgery plus accelerated rehab, it's a combination. And so, Will hears us talk about this all the time, but it's not, we're orthopedic surgeons, but we also specialize in orthopedic post-operative care. We specialize in preoperative evaluation. It's not just doing the surgery. We love the surgery part, but I also love good outcomes. And so the key here is with seeing with Dr. Weil, the same thing. It's just continuing, how can we fix it on every level? It's a supply chain, kind of machine system we have to have, but you got to make sure that every part's working correctly or you're not going to get a good outcome. But if you do it correctly, you get good outcomes appropriately. So.
Yeah, and it's a good reminder also. We had talked about this on one of our other shows about technology and biofeedback, and you're talking about this Rebless, right? That was that H Robotics one that we talked about.
Yes.
Please
look at our previous episode to learn about it.
The physical therapy device for both upper and lower extremities. And Dr. Weil said it perfectly, right? The elbow, the wrist, the ankle, knee joints. So as a patient, right, as someone that's going to come into your office and have something done and knowing that, okay, that's step one, but now what's the next step to get back to having some normalcy, right? To get back to doing the things that we want to do, whether it's, grabbing my coffee mug because my thumb is now fixed and I'm, getting treatment, or, going for a run because now my knee is fixed. So from the surgery through the rehab and having technology, that's really exciting for us, but I know for you guys too, because it's like new toys. So it's really exciting.
Yeah, it's like I said, it's really, I think the golden age of orthopedics is upon us, and we are having this huge merger of high tech computer electronics and old school anatomy and surgery. My kids ask me all the time about the bionics and the $6 million man and all that. I think forget books. I mean, it's closer than we think, and it's really exciting.
Especially with inflation, you may be $6 million man sooner or later.
Oh, yeah.
I think we're going to have to wrap up soon, but Dr. Weil, can you tell us anything sort of, hand, wrist, what are you most excited about in the future? Anything you've heard about that you're looking forward to, kind of read about? I know you're dabbling, you talked about the tightrope, you talked about some implants you're using for the thumb. Is there anything else you're kind of thinking about in the future that may be coming? You got to learn a little bit more about it for the listeners so they can kind of get excited and maybe check you out in the future and find out if there's something you can offer for them?
Yeah, I mean, from a sci-fi perspective, a lot of interest in just robotics and biofeedback and for our severely traumatized patients, one day being able to provide them with a real useful and working robotic hand as opposed to just a hook. But that's pretty far out there. I think more closer on the horizon is the continued sort of miniaturization of our implants that we use and tools that we use in other body parts. The fact that we're now able to get cameras that are small enough to fit into the small joints of the wrist and the hand really allows us to kind of move hand surgery forward, kind of like the knee and shoulder docs have been able to do over the last 10, 15 years. We're going to be able to do all the stuff that they do, just on a much smaller scale. So that, I think, is quite exciting. And then the other one that I think is really important is sort of nerve recovery and nerve regeneration. So you slice your hand and you lose feeling into your fingers when you're taking out that avocado pit or slicing the bagel and you slice open your hand. Really getting nerves to regenerate quicker so we can repair your nerve and you get sensation back into your fingers faster. All that, I think, is really exciting.
Well, we just opened up another Pandora's box, so we're going to hold off on that until the next time we have Dr. Weil on. But the nerve stuff is a whole other ball game.
I got one more question before we let him go. Yeah.
We can talk about kitchen knife injuries next time.
Oh, no. One last question before I let you go. As a parent, and I know everyone on the call is a parent, we have our little ones, and they fall, and sometimes they're like, oh, ouchie, or something like that. But is there a, lack of a better word, a simple sign where you need to, as a parent, say, you know what, you should go get your child checked out as far as a wrist? I had a friend that their daughter fell. You know, they complain a little bit here and there, but didn't complain much because, just to remind everybody, there's 8 bones in the wrist and 27 in the hand. Yeah. So you might have an injury that doesn't hurt that much, but something is wrong. Is there a sign, as a parent listening, that if your young child that may be having a trouble communicating displays or exhibits this, you should go have them check it out? Yeah,
I tell this to my patients and friends all the time. Kids are smarter than adults, right? Adults, always are trying to play through the pain. Whereas a kid, if something hurts, they're not going to use it. And so if all of a sudden, you notice that your kid isn't, grabbing stuff with their hands normally again, or they don't want to ride their bike, or they don't want to go out and climb trees because their wrist or their hand, it seems to be bothering them. Those I think are telltale signs that, something's wrong. When there's sort of this immediate change in behavior, where you had a kid running around yesterday and now they're kind of mopey and not wanting to do the normal stuff that they usually do.
Great. Thank you so much. Dr. Weil, please, everyone, orthopedic specialist of Seattle, check out Dr. Wayne Weil at Seattle Hand Doc as well. I mean, you got to read his bio. I mean, from where he's been, where he's graduated, NYU. I know you're a Maryland guy. I mean, marathons, triathlons, Ironman. We didn't even get into that. I had a whole other thing for you there, but we don't want to keep you up. Dr. Weil, thank you so much for your time this evening.
Thank you. Thanks, you guys. It was great chatting with you, and hope to do this again with you.
Okay, thank you.
Thank you very much for being on.
Dr. Garcia, once again, great guest. Initial thoughts on what we just heard.
I just love hearing the innovation. You guys always get to hear me talk about all the fun, fancy stuff I like to do, but, I only do 3 joints, and there are a lot more in the body, and there are a lot of other bones and other things that we do. And I think what you're seeing is that we're in a day and age, especially in a Seattle practice that we have, or in a downtown city practice, you have to be super specialized. And there's so much to keep track of. You really want to make sure that you're getting the person that does the most of this and understands the most of this. So that's really what our practice has turned into. And patients expect that. The days of going into somebody that does everything is it's important, but really that subspecialist, super specialist can really help out and pick up on things. Like you talked about for the hand. You're 40 years old. You're not going to get a 7-year-old procedure. Yeah. Now we have procedures are set for each age limit. So it's really important for us to understand how this works. It's important for patients to be informed too. The number of patients that come in, they're like, I had no idea that was an option. That's why we do this.
Yeah.
Right? We teach them about what's out there, what can be done to get them to do better. And so really it's important for us to make sure that we educate the patient population, from the Seattle area to throughout the Washington state, et cetera. Or people that listen to our podcasts from elsewhere. We've got people from outside the country listen to this.
Yeah.
Hopefully they can have those options where they are. So that's really what our goal is to inform patients and just to show them how excited we are for new technology. And, it'll be exciting in a year or two to update on this and find out what we heard, what happened, what didn't happen. And that's the way technology works. So we want to keep people updated. Again, all sports, all orthopedics, really maybe all innovation would be another thing we could add to our title at some point.
I like it. No, definitely. It was great to kind of circle back to the technology we've talked about before with Rebless. I was like, oh, H Robotics, Rebless. I know exactly what you guys are talking about. So it's really exciting to hear that the different ways that all of this is being utilized, from, the knees to the wrists and, hands and so on and so forth.
I need to remind the listeners that despite while everyone thinks that Will Sanchez is a doctor, he's still in training. We're still working on this. But you may think he's a physician from this podcast, so I've been impressed.
Thank you. I'm working on it. Secretly, I'm just gonna walk in with scrubs one day and say, "All right, Dr. Garcia, move over. I got next. I'm doing this internal bracing." So that'll be great. But Dr. Weil's absolutely incredible. Check out his resume, from NYU Hospital and, shock trauma hospitals. And, I wanted to ask him, I said, listen, you're from Maryland. Are you excited about your Baltimore Orioles that are playing so well? Or, you've been here, I believe 18, 19 years, something like that. You correct me if I'm wrong. Is he a Mariners fan? So, what gives here? But I think he's a
true Seattle guy now.
Oh, really?
East Coast up, but true Seattle guy now. Yeah, we live in Seattle, you become more of a Seattle. Except for me, I'm still the New York guy.
That's right, baby.
I still like the Giants. We know this, but that's just you and me. We're different.
His Orioles are doing well this year, so I didn't know. So I wanted to ask him, but we'll save that for another time. When you bump into him, ask him. That'll be around the round table when you guys are hanging out and say, hey, by the way, you still Orioles fan or you on the Mariners bandwagon? But Dr. Garcia,
maybe I'll give you an update next talk.
That'll be great. Dr. Garcia, thank you for your time. Check us out, sportsdoctalk.com. All sports, all orthopedics, all the time. I'm Will Sanchez. Dr. Garcia, thank you very much, Dr. Garcia, for your time today.
Thank you so much. Looking forward to it. Check us out and check out our previous guests and check out what's coming up.